We explained that. Good afternoon, everybody. Welcome. This afternoon, it's the NHS University Hospitals Liverpool Group Board of Directors to see everyone. As usual, we are live streaming our meeting, and the recording of the meeting will be on the website in due course. A couple of apologies for today. To start with, firstly, I should mention Chief Executive's on the screen. He's not been well. He shared details of his illness with me that I didn't really need to have, but it helped come to the decision that we're better off with him not in the room. It's an infectious time, so not no one's fault, not ideal, but James will join with us from the screen. Apologies from Jackie Berg and from Claudette Elliott, both that intended to be here today, but different family issues that required their presence at very short notice. They talked to me about it. I understand completely, and I've asked Mike to step back and to be deputy chair for this meeting today. We're also missing Sarah Walker and Jenny Hannon, executive managing director from Women's, is away, and I welcome Jenny Hunt. That's right. Okay. Now today we're joined by David Bennett. Welcome, David. David is a non-executive director on the main national board at NHS England, and in view of the complexity of the challenges that we face in our trust, the scale of the challenge in the look bit of our agenda, and the work that we are doing with the other huge adult specialist trusts through the last program. We feature on national risk registers and our national profile with all of that. And David's here to take a first-hand look at how it all works around here within our group and out with the group with others. I've known David a long time. Really welcome you, David. I look forward to working with you through this period. So, with a number of people who are joining us for various items as we go through the agenda. But at this time of year, it's now 75 days till the end of the business year. And this sort of boards all over the country meeting in the middle of winter will be, while we're sat in the boardroom, there are immense pressures at this hospital and other hospitals in our group dealing with the demands of needs of patients during this intense period of time. We'll get into some of that discussion a bit more deeply today. Our reporting, because of the holiday period, the formal reporting in our papers takes us to the end of May, the end of November. And of course, in the 5 or 6 weeks since then, a lot has happened. We need to formally report a position, but recognise that lots of things have been going on, lots of activity in the intervening period. And we look to receive the formal reports, but also get a flavour of whether it's in the financial or operational performance, where things are at in a more real-time way today. You don't need to be watching the news flow to know that there's ongoing focus in the minds of the public, and in the minds of the government and NHS England, so on where we are in managing our resources, where we are in managing our waiting lists, where we are in responding to those winter pressures. Now, it's important for the board in all of those things that we seek the assurance that we're on top of the issues and are doing all the things we can to deliver best for patients. But that in itself is not the full spectrum of our agenda. And as is usual on the agenda today, with a number of governance issues to tie up, which Daniel will lead us through. And then we've got a crucial suite of papers on the quality and safety and people issues. We'll go through the full range of our business, giving equal priority and urgency to all of those things. So, anybody feel any particular conflict of interest in any part of the discussion, the usual rules, please identify that at the time and we will be able to manage them. Okay, so before we get into business formally, as usual, we start with a story. Today's a staff story about the skin analytics. I've had a preview of the presentation. It's all interesting and impressive stuff, Jim, and I'll ask you to guide us through it.
Thank you very much, Chair. So in a moment, I'm going to introduce Richard R. Zerdia, who's one of our consultant dermatologists based at Royal Green, who's going to talk to us about the skin analytics programme. We've got a few AI-based diagnostic programmes running across the group, in particular around the analysis of chest x-rays, another piece of work around histopathology for prostate cancer. And there are plenty more coming, and we're being cautious and circumspect about governance that sits behind these pieces. But probably the one that's most advanced is Richard's work around skin analytics in the differential diagnosis of skin lesions to exclude malignancy. And so Richard's a busy chap, and he's got a clinic going, I think. So he's joining us online to take us through the progress that's been made on skin analytics, which I'm sure everyone will agree is impressive and has a great future. And we're always mindful about trying to improve efficiency in these pieces. And we are, I believe, starting to see some real progress in that space. So that's very exciting. So Richard, thank you so much for joining us. The slides are in the pack, and it'd be great for you to take us through them, and then I'm sure Chair will have some time for some discussion. Okay, thank you.
Okay, thank you very much for the invitation. Can you hear me all right? Can I just confirm you can hear me okay?
You can.
Great. And am I just asking someone to move the slide forward? Is that okay?
Yeah.
Thank you. So my name is Richard Zerdia. I'm a consultant dermatologist in the Trust and the secondary care clinical lead for dermatology in Cheshire and Merseyside, and leading on this project. Next slide, please. So this is our problem in dermatology, and you can see that this is the numbers of urgent skin cancer referrals per year. And in the last 10 years, we've seen a doubling of the referral numbers, so that now in the last 12 months, we were nearly 10,500 referrals just for suspected skin cancer. And of course, this is in the context of a department that has a general waiting time of about 12 months. Next slide, please. So we have to do something different, and Skin Analytics have developed a AI product called DERM, which stands for Deep Ensemble for the Recognition of Malignancy. It's the only UK CA Class 2A certified device in the UK, and it's also got European certification for autonomous decision making. Last year, it had a NICE EVA assessment, which was successful. Next slide, please. And this allowed for people to utilize this tool within the NHS and to use it within the skin cancer pathway, which obviously was a significant decision last year. This decision is so that over the next 3 years, further data can be produced and analysed to give full approval, hopefully at the end of that 3-year period. Next slide, please. So in terms of Cheshire and Merseyside, the relationship with this company started back in June 23 when this pilot started in mid-Cheshire, And we as a trust started in March 24, piloting initially just in one location in North Liverpool. And you can see the timeline has now brought in numerous trusts across the Cheshire and Merseyside patch. Next slide, please. And in that 12-month period, you can now see that 14,500 patients have now gone successfully through the skin analytics pathway, which suggests a significant escalation of workload through this route in the last 12 months. Next slide, please. Now, this is a post-referral clinical pathway. So what that means is a patient who attends the GP, perhaps concerned about a skin lesion, will then be assessed by their GP or primary care physician. And if concerned, the primary care physician will then refer the patient on the 2-week rule pathway, now known as the urgent skin cancer pathway. And with the patient's consent, they can be sent on this AI pathway. The patient is then invited to attend a local photographic hub for image capture by an HCA or a medical photographer, and the dermoscopy images that are produced are then assessed by this derm AI tool. Now, if the assessment comes back and it says it's probably benign, we have a safety net in place where this is second read by a human dermatologist. And if the human dermatologist agrees that it's probably benign, then the patient can be discharged without face-to-face review. If the human dermatologist disagrees, then a virtual or a face-to-face clinic appointment can be arranged. Now, of course, if the AI tool suggests that it could be a melanoma or a squamous cell carcinoma, so one of the two more serious skin cancers, then a virtual clinic or a face-to-face clinic review is arranged. Next slide, please. So these are our photo hubs across the Liverpool area, and of course we've covered that. The first one was in Kenilworth Road, which is in North Liverpool, and then we use our base at Broad Green. We also use our base at Aintree Hospital, and our central Liverpool base is at Paddington CDC. Next slide, please. And since last month, we've been doing virtual urgent skin cancer clinics as well to tie in with this program. And these virtual clinics allow us to review images following primary care referral within the skin analytics portal. Now, this relies on excellent photography and image capture, but of course it allows efficient working and reduces the patient touch points. Now, that has the advantage of improving the faster diagnosis standard, or FDS, which can benefit the overall trust position for cancer and help us achieve the key NHS cancer standards by streamlining care in a faster way. Next slide, please. So when we've assessed a patient, we can then discharge the patient directly to the GP with treatment recommendations and safety netting advice and patient information leaflets. We can now book patients directly in for surgical procedures and biopsies. We can arrange face-to-face review in appropriate outpatient clinics if there's a more appropriate setting. And we can, of course, refer directly to appropriate specialist clinics like in plastic surgery and MaxFax, therefore negating the need for the patient to attend dermatology and then be told to go somewhere else, and it just streamlines it better. Next slide, please. And you can see that in the last 12 months, having started small in pilot form, we've now expanded and we're pushing a lot of patients through the Paddington CDC, which is the orange colour, so that we can generate more and more patients through this pathway. The aim is to try to get 80% of our urgent skin cancer patients through this pathway, and we're about halfway there. Next slide, please. So this is just 1 month sample, but from last year, sorry, I beg your pardon, last month, 352 cases came through our virtual skin cancer clinics with a derm discharge rate of 40% and a face-to-face avoidance rate of 80%. So that's a large number of patients who we've managed to avoid attending the hospital and in place got made treatment decisions and plans for them. Next slide, please. Now, what are the safety aspects? Well, they're obviously very important, and probably the most important part of these AI tools, and derm sensitivity monitoring is paramount. What we're trying to avoid is false negatives, and the sort of dial between false positives and false negatives has to be monitored very carefully, so that patients aren't dealt with inappropriately. Comparative histology data is sought from all the trusts, so we have to provide data to the company so that we can compare what biopsies have shown and what diagnoses were thought of, and the comparisons are made appropriately. Regular audits have to be done, and we've been doing second read audits as well to look at the impact of the human second read. And of course, this all contributes towards the NICE data collection, which needs to be done by over the next 3 years. Next slide, please. And this is an example of the national performance of derm, which is closely monitored, not just in our sites, but across 30 sites in England, or 65,000 outcomes with over 6,000 biopsy confirmed cancers. And this system is performing above the targets on the left-hand side for melanoma and SCC. And these targets were set based on how good a consultant dermatologist should be. Obviously, a tool like this should be performing above the performance of a consultant, and it's been shown that that is the case both in all pathways and of course locally in Cheshire and Merseyside. Next slide, please. So next steps, moving to autonomous. Autonomous basically means that we would remove the human dermatologist's second read and rely on the computer to decide on the diagnosis and discharge people appropriately. This has already been done in Chelsea and Westminster and a number of different trusts in England, and we've also started to do it in a number of trusts in Cheshire and Merseyside. We've not done it at this trust yet. This will of course support recovery of the dermatology backlog by releasing core clinical capacity and improving our RTT performance, because we have 12-month general waits for patients. And of course, within those 12-month waiting patients, there will be patients with skin cancers who are having to wait a long time, which is unfair and unsafe. We also hope to reduce the need for ACC payments and locum spends by implementing such a system. This is, of course, balancing it against patient safety and patient feedback, which has largely been very good, clinician confidence and clinician feedback, both in primary care and secondary care, and weighing up the benefits and the risks. Next slide, please. And this just gives you an example of potential benefits going autonomously across Cheshire and Merseyside. Even if you had a second read in place, you would still potentially save 9,500 clinic appointments per annum. And if you did full autonomous, then you're looking at nearly 13,000 clinic appointments per annum. Now that's across Cheshire and Merseyside in dermatology, but in our own trust, that could be anything up to 3,000 appointments. And my final slide, please, is just a recognition of the fact that this project is run by dermatology, but there's lots of people involved both in this trust and in primary care, both in the ICB and the Cancer Alliance, and I just wanted to name a few of the most important people in this project. Thank you very much for the opportunity to present today.
Thank you, Richard. An excellent presentation of really impressive work, and in this board over all of our time we wrestled with the problems of outpatient responding and being able to respond to the demand in outpatient clinics, and also constantly seeking faster diagnostic access also. So it's a great story that brings those things together. But Jim, back to you first before I open up.
Thank you, Chair, and thank you very much, Richard. One thing I want to get across is that I've seen you in action talking to GP colleagues and colleagues across the system to educate and reassure, and in a sense bring others with you and with us. So for me, there's something in this about all of these initiatives about making sure we take everybody with us on the journey and reassure them about the safety and so forth. Where would you say we're up to, Richard, now in that regard, in terms of how this is seen by our GP colleagues and by patients across the system?
So there are we do have tools by which we can seek feedback both from patients and from primary care, and we do try to keep people engaged. I would say that the majority of the feedback is very good, particularly from patients. Patients are really seeing the benefits because I'll give you an example. A patient who I saw yesterday, for example, was only photographed last week. I didn't see them yesterday. I virtually saw them yesterday, and I'm planning to put them on a surgical list tomorrow, and another patient next week. So it allows you to streamline really very, very quickly those sort of patients, and therefore feedback is generally good. What we've got to be careful of course, is that communication is paramount, and you can't list patients without making sure there's good discussion with them and there's full understanding about what they're being listed for, etc. So I think there's work to do on some of those aspects, but generally patients want things doing quickly, and if you go to your doctor about a skin lesion, it's usually because you either want it off or you want it treated. So you're pushing on an open door when you suddenly say to the patient, we can offer you a procedure to have that done. In terms of where this is for primary care, we've had a bit of an issue because we withdrew Synapsis, which is a teledermatology A&G system, and replaced it with this. So there's been a little bit of working with the GPs to try to understand why we've done that and what the benefits are likely to be from implementing this. There was quite keen discussion around making sure there were enough hubs around the city so that they were accessible for patients not having to travel so far. So those sort of things have been important to try to implement. And from a secondary care perspective, colleagues really want to make sure that this is safe moving forward towards an autonomous piece. And I think our main issue recently has been photography quality, and we've had a couple of issues with that. So we are making sure that we've got that improved before we push on that side again. So there's lots of things going on.
Thank you. Thoughts, questions, reflections on the presentation? Start with Jeffrey, please.
Thank you for an excellent presentation and great gatekeeping and progress. The first part of my question is, in terms of, you've seen a doubling of referrals in the last sort of 10 years. In terms of the analysis, the positives and the negatives, does that remain at the same kind of percentages, or are you getting more negatives now with increased referrals?
I mean, I think traditionally, most of the urgent skin cancer pathways like this across the country bring in a cancer hit rate, if you like, of less than 10% on the referral rate. So my own view on it is that although skin cancer numbers are increasing, they're not increasing at that level. And I think part of the problem is that when a patient sees a GP, their option is 2-week rule or urgent skin cancer pathway, 12-month wait, or advice and guidance. That's essentially the options. And so, quite a lot of primary care physicians will then choose the urgent skin cancer pathway because it's the easiest route in to the service. And I think that's historically been part of the problem and still the problem moving forward.
Second part of the question is, I was delighted to see how you're working in primary care. My previous role at the CCG in St Helens, we had a GPSI on dermatology, which was really useful, and sort of was a sort of midway gatekeeper. But we also saw a huge rise in what one of our GP colleagues on the board would call the worried well, who were going to the GPs at sort of lumps and bumps. And certainly in St Helens, they stopped removing skin tact, which is often something people go with. So I think the working with primary care and getting clinicians as up to speed as possible, and with primary care nurses as well, is really important. Delighted to see that's what you're doing. So I commend the work you're doing. It's fantastic. Well done.
Thanks, Jeffrey. Matt, then Heather.
Thanks, Richard. I think that was a really good presentation, and I think it is a phenomenal piece of work. I think autonomous is generally where we'll see AI move, because if you think about it, as it stands currently, it's partially automated, then you've got a human in the loop that does that second read. when we sort of free up that full capacity, so it's fully digitised, that's where we want to get those benefits, and you really sort of demonstrated that in the slides, I think. I think my sort of point really is we need to be a little bit careful around when it gets it wrong, which it will now and again, because we must forget that humans get it wrong. And the risk is because AI does it, it's fundamentally broken. A couple of things for me. When AI gets it wrong, we can learn from it because it's more systematic, so we can develop it, it will mature. Particularly around edge cases as well, as it gets more, so as it becomes more mature, it will get better, and we can work with technologists to improve it. We've got AI governance now within the group, which supports this type of work. And I must admit, Richard and the team are leading the autonomous piece. So I think the other bit we must forget is because the throughput, the waiting lists are less, people are worried, well, actually what harm could be happening to those patients who wait longer. So there's so many benefits, we mustn't forget that. But for the times when it might get it wrong, we need to take a balanced view on it.
Yeah, thank you, Matt. Heather, please.
Thank you, Richard. I'm Heather, the Chief People Officer. I'm really interested. Dermatology has been a really challenged profession, hasn't it, in terms of attracting people into the profession. And I'm interested in whether you've developed new roles yet, or you're attracting more people into the profession because of the sort of different ways of working. And does that create a more sustainable workforce for you going forward?
Yeah, I mean, I think it's an interesting question, because I think we've actually been very blessed in this trust that we have been able to recruit. So we are a recruiting trust. That the advantage, I think, is that we have a lot of registrars that come through the department, and then we're able to sort of they're able to see how we work, we're able to see how they work, and so we've had a slight advantage in the sense that we've been able to encourage and try to create roles for different consultants coming through, and also with that in mind, job planning, advantageous job planning can then be utilised. So, for example, virtual clinics potentially could be done out of hours. Advice and guidance could be done out of hours. You can work flexibly with some colleagues so that they can have a job plan that maybe works for them as well as works for the service. So I think the answer to your question is we're very lucky in Liverpool that we've managed to maintain a big department and encourage new doctors to come through and join us. And I think not every dermatology department is like that. Others do struggle, particularly small departments struggle to try and recruit and then deal with all these issues, and it can be an absolute nightmare.
Thank you. Okay, thanks everybody. Richard, it's great. Thank you for carving out the time to come and join in our meeting today and tell us the story. It's very impressive, and we look forward to hearing updates as we learn more going forward. So thank you very much indeed, and please pass on our thanks and congratulations for the work done to your colleagues in the team.
I will do. Thank you very much for the invitation, and pleasure to talk to you today.
Excellent, thank you. Right, let's look at our minutes of our last meeting, which was on the 13th of November. I've not spotted any specifics in there that we won't be able to connect with items on the agenda later. Any questions, concerns with the minutes before I see them? Thank you. Can we then formally approve the minutes of the meeting? Thank you very much. There are 7 items on the rolling action tracker without me running through all the comments. Some have been closed by moving into the relevant committee. This will come back later, Daniel. There's nothing else I think I need to track.
No, Chair, the 2 are coming back in March, as indicated. There's a couple of activities that we've done. So one of those was in relation to absence and attendance. Obviously, yesterday, the Assurance and Risk Committee, we started that process with a deep dive look into it. And obviously, an update would be presented as part of the group transformation plan. But the rest of the information of the complete ones is contained within the pack.
Thank you. Everyone content? Thank you. I'm not notified of any urgent matters arising. Clearly, as I said at the start, we're in winter, intense winter pressure season. I'm sure all board members entering the site this morning counted the ambulances at the front door. But I'm guessing, James, through your presentation and the discussion about performance and so on, we can touch on the sort of real-time status of where things are at. I think we were talking to colleagues earlier today, and as we said at the ARC yesterday, our teams at the front door are managing fantastically well. And I reflected back on our discussion this time last year at the board when we felt less on top of it, less in control than we do now. And no one knows what the afternoon and tomorrow brings, but my oversimple summary of so far so good on that. But if you could give us a bit of a flavour of how all that is going across, particularly across the two emergency departments. But that was the only sort of real-time matter arising I wanted to refer to, and I pass to you, James, for the Chief Exec report.
Thank you, Chair. Can I just check you can all hear me all right?
Yes.
Good. Okay. The screen's quite slow from this side, so if at any point it's not working from this end, let me know. Thank you, Chair, and apologies again for not being able to be there in person today. And again, apologies to David Bennett for not being able to meet up yesterday. I hope we can rectify that soon. My report today, I'll start with the CEO report that's in the pack. We've got the performance report that follows it, and of course that's got the IPR metrics in. Obviously, we've had the Assurance Risk Committee this week, which is obviously recorded and put on the public website, where we've discussed some of the matters in detail, particularly some of the A&E issues, but I'll look to colleagues to update on that shortly when we get to the performance reporting. The key things I just wanted to highlight today, we included in the report this time a bit of a wrap-up of where we finished the year and where things are heading this year, of course. One of the big things this year is obviously the launch of the UHL 2030 strategy. The final draft, or the medium-term draft of that, is in my inbox that Tom has been working on throughout the Christmas period. And just a reminder to all of us about how important that is, particularly because it focuses back onto a population-based analysis of what our population require and the 3 new care models. And it was really striking listening to Richard there, who described perfectly almost that diagnosis and treatment model, which is a core of our new strategy. We landed on that specifically because of the problem that primary care face in trying to choose an option between an either very urgent referral on a 2-week wait or a very long wait on an elective pathway or an A&E, and not a lot in between. So that was a great example of diagnosis and treatment treatment plans, which brings into use technology. So I just think that's a really good part of this morning to concentrate on when we get to the strategy over the next few weeks. So you'll see more of that coming through strategy and partnerships over the coming weeks. And what we'll try and do is in those meetings set into the context of that strategy alongside the work we're doing in LASP and the bringing together of the group model or wherever that takes us. I did have in the report a welcome to David, but you've already done that, Chair. So, but I'll just reaffirm that it's going to be great to have David's view on some of the things we're doing and trying to do as we go forward over the next few months. I wanted to just touch on the last clinical transformation work. Andy Nicholson, who is the Chief Medical Officer at the Walton Centre, has obviously been leading that clinical reference group, and we're starting to see now really good work coming out of the individual groups. Cardiology, in particular, presenting to us over the last month the opportunity that arises from having 3 separate cardiology services effectively within one city, and what could be done. And again, what's coming out with as a real strength in that work is again this opportunity to link better with primary care, use advice and guidance better, and in particular provide opportunities to diagnose and provide treatment planning back to primary care quickly. So I think we'll see a lot more of that coming through the board over the coming months. The governance changes, just to touch on that now, to be clear on this, this is a UHL of the 3 organisations change that's aligned to where we're heading with LASP. So we always planned as the 5 organisations in the future to move to the bringing together of a smaller amount of management boards within the organisation overseeing multiple sites. The importance of the site structures was really to represent the fact that we've got specific linkages between hospitals that are often next door to one another, but also specific linkages based on patient harm and patient risk. So Liverpool Women's and the Royal being a key example, and the need for the Royal to lean further into the Women's in terms of medical support and other things, and also for the Women's to have better access to the Royal in terms of cancer surgery and other things that they need to do. So this is all in line with that work that we've described at the Joint Committee last year, and we're moving to this new structure of the 3 hospital management boards. We're planning that from the 1st of April. Aintree will stay as is. The Royal Liverpool and Liverpool Women's will come under one management board to try and really drive that work that needs to be done around the bringing together of those things I've just described. And then Liverpool Heart and Chest, Broad Green, and the Diagnostic Treatment Centre as well. This starts to get us to the point where we've got similar size and scale across the organisation in the layers of management that sit beneath those management boards. It obviously develops savings financially because of the scale, but also, more importantly, similar structures and therefore opportunities for people throughout the group. So that work's all underway, and a really important part of that is obviously the delivery of the corporate services. And the corporate services are now being redesigned across the 3 to align to those structures from the 1st of April. I've been chairing the programme board for corporate services, and we've so far had good presentations and approvals for many of those from corporate governance. We've had this week, I believe, the HROD chief people structures, and we're working on finance and others now. So those shall all contribute to, again, financial benefit, but importantly, alignment to the future management structures. Now, I wanted to reference the enforcement undertakings. NHS informed us in October that a number of those enforcement undertakings would be updated to reflect where we are. And we also got those at Liverpool Women's Hospital. Excuse me. The Women's Hospital was largely focused on performance challenges, as we know, and for Luff that was much more, well, solely focused really on the financial challenge. We now are anticipating the final confirmations of these. We've submitted our responses earlier this week, and we're assuming that these will remain in draft form until those are finalised, and then they'll appear on the NHS England website shortly. Well, I put a note in on palliative care largely because the board discussed this and sought further assurance. Now, again, just to remind people, this was Marie Curie exited a number of their responsibilities within the city, including bed-based palliative care, and that was leading to people being stuck in hospital on end-of-life pathways, which is absolutely not where we needed to be. We've worked with the ICB on a solution to that, and the teams between the Royal and also more so now between the Heart and Chest and Broad Green have come up with solutions to that, and I'm pleased to inform that we will be ramping up that palliative care bed capacity over on the Broad Green site from later on in January, and that will make a big difference to those families and those patients that are getting stuck in the current system, and we will obviously be recompensed by the ICB for doing that on a temporary basis until that's then recommissioned in some way in the future. I also just wanted to touch on the industrial action, because that was obviously another key challenge for the organisation, and it feels like a regular one now, but we did have what we assumed would be a very tricky 5 days from the 18th to the 22nd of December. I just want to thank the team from the EPRR team, and also Jim Gardner, who led on this with the sites as well, because I think we had a really good result for what was a really difficult and challenging time. The absence rates were about 30% across the region, as it says in the report, but what we managed to do was keep activity at over 90%, and there were no priority 1 or priority 2 delays, which, given the time of year, sickness rates at the time, and also where we were just ahead of Christmas, I think is really good. So no issues reported from that. I did want to just mention that later on in the agenda, we'll be looking at the MOU for the North Mersey Provider Partnership. That's the collaboration between Alder Hey and Mersey Care and ourselves. As you know, this is critical again to our strategy about how we integrate better with the community-based responses and neighbourhoods over the coming years, and in particular how our three organisations align our community service offers in a different way. So that work's been going really well, and I think Tom's going to just take us through the MOU later on today in the agenda. They were the key things, Chair. I think the performance report is obviously next. The ARC report is attached from the meeting that we had, I think it was only yesterday, so people can see what was discussed there. And we did obviously go through a lot of the performance and financial risks and other things as well. And the risk register is obviously attached. So I know the board discussed those at some length yesterday, so I wasn't going to repeat those again today, but the papers are there. As is the video of the meeting on the website shortly. So happy to take any questions on those before we move into the performance report.
Thanks, James. Points, questions, reflections, so. Yes, Sue.
Just a quick point on the industrial action. That's great to see that 90% of the activity was achieved. Were there any sort of lessons learned? Any sort of more negative consequences and impact of things that we need to consider sort of going forward?
I'll pass that to Jim if I may, Chair, just to come back as Jim's chaired the meetings that have overseen these.
So actually, we've got a full review tomorrow morning, which we do after each one of them because we run these through the EPR system for the group. I suppose the positives are that when we do put in these grip and control systems, which Beth and many other colleagues in this room are part of, we're quite effective at running the organisation. But we can't do that all the time because it's incredibly intensive. There are some interesting issues around skill mix, which lead us into some reviews of our skill mix in normal times across the organisation. So as an example, there is a hypothesis, at least, that if we change the skill mix at the front of the hospital, we can reduce the number of tests that we order, we can reduce the number of admissions that are made, and therefore run in a different way. But we don't really know whether that's sustainable. So, and we see different professional groups coming into play, which is very interesting. So there is lots of learning. Perhaps the last thing I'd say is, oddly enough, I think these events are quite powerful in bringing people together. It's a team sport fundamentally. So lots of people get involved in, going the extra mile definitely, but also being passionate about making sure that the service works. And that has, strangely enough, I think, has a positive impact. I'm not hoping that we have more of it, by the way, Chair, but but in all seriousness, so we will do our full review tomorrow. And we learn each time we do it.
Thank you.
Thanks, Jim. And the right for that come back here will be first consideration.
Yeah.
Beth, you want?
I just think, I think it's also worth noting on lessons learned. There was also that approach taken nationally. So Jim Mackey, prior to the industrial action, had meetings with the chief operation officers nationally and also the chief executives, and they proactively asked for feedback of what worked last time, what didn't. So an example of which is the information submissions over that weekend caused a few problems. So they were very proactive in listening to us, they were reaching out, let us know, and were prepared to actually change the position. So it wasn't just local lessons learned, there was also national learning as well. Thank you.
Thanks. Any other points for Chair? Yes, Donna.
Just, it's not necessarily a question, but in terms of the draft enforcement undertaking, we did get a query in from a member of the public yesterday, just inquiring about what the impact of the enforcement undertakings will be in terms of the public and also members of staff. What we responded to that today, advising that obviously once the enforcement undertakings have been finalised with colleagues from NHS England, we'll be publishing them and we'll bring back a formal paper to the next board meeting.
Thank you. That's good. Okay, should we move into, James, then move into the performance section? As you say, because of the holiday period, we've ended up with back-to-back days of assurance and risk and now board. We spent 2.5, 3 hours yesterday, predominantly on operational performance and money. As you say, anyone wanting to observe our discussions in more detail on that can watch the recording. But do you want to just highlight where we've got to, and at this point, I'd like to touch on some of the winter pressures?
Yeah, I think what we'll do, Chair, is if it's okay, Beth will take the performance report because that's her one, and then I would suggest if you find it useful, perhaps again, I can't see exactly who's sat where in the room, but if Nat and I thought it was Shahida today, but I think I can see an outline of Peter. Good to have a conversation just about current events in terms of this week and where we're up to with the urgent care in particular. That would be helpful. I think also, I'm sure Beth will cover it in her report, but if you look at where we're heading into Q4, the key risks are obviously around the Liverpool women's elective position and also some of the Luft elective position, but we've got some good progress on the cancer work. So Beth will cover those things, and then we can go to the others for urgent care, if that's okay.
Yes, thanks, Beth.
Thank you, Chair. So you'd be pleased to know that I have covered a little bit of the position, the more recent position for December. So for November, you will note in the paper that there were 17 metrics that displayed statistically significant improvement. 6 of them were at the women's, predominantly across the quality and safety and clinical effectiveness metrics. 6 were at Luft, predominantly operational, and 5 at LHCH, again, predominantly operational, but there were some people and policy in there as well, Jonathan. So it does reflect the good work that's going on at site level and also the delivery of the local improvement plans. What remains to be a challenge is the delivery of the UEC targets, and as James has quite rightly said, the elective targets also. So I'll cover the UEC targets first. For 4-hour performance targets, we were behind trajectory in November for both footprint and for also 4-hour. What I will say is that we remain in the median, the second quartile for the footprint performance, but I think it's more of a challenge for us for 4-hour type 1, which we do remain in the bottom quartile. But I know that Nat and Pete will talk about the local improvement plans, and I know there's still work going on. In terms of ambulance handover, we were ahead of trajectory in November, and I'm pleased to report that that has remained. So we are doing a lot of work with NWAS to maintain that position. And you will note also in the report that the women's seen a significant deterioration of around 9% for their A&E performance, but that has since recovered and we're back up to 89% in December. For elective, we finished the position in terms of 65 weeks, patients waiting over 65 weeks, with 10 in November and 5 at the women's. And I'm pleased to say that we have finished the position in December, 0 at Luft, but unfortunately we have seen a deterioration at the women's. But the team have worked incredibly hard. We did forecast 15 to 22 patients, and it's actually 15 patients. And it is worth noting that some of that is as a result of the outsourcing company had changed their position on the service that they were offering. We've worked closely with the women's team, and we have put recovery plans in place for January. From a 52-week position, LHCH, women's, and also Luft, we are behind trajectory. However, we have improved again in December. And from an RTT point of view, Jonathan, you're ahead at LHCH. Luft and the women's are behind trajectory in November, but we have closed the gap, so moving in the right direction in December. I think at this point it's worth noting that there has been a request by the national team of what we can do in terms of our recovery plans and accelerate that performance by the year end, financial year end. And we made submission on Monday. That's gone off to the regional team, and we have yet to receive feedback on that plan that we've put forward. But that will include outpatients as well as inpatient workload. So I've been working with Rob on that from a financial point of view. From a cancer point of view, James has just touched on the fact that we are again making inroads into our recovery plans for Luft for October. Remember, there is a lag on the cancer performance. We were ahead at Luft, ahead of trajectory for both FDS and 62 days. So I'm really pleased that our patients are receiving the outcome of their diagnosis within 28 days against trajectory. The women's were significantly behind trajectory in October. But again, I do want to note that on the last tiering call, we remain in tiering at the women's for cancer, but it was recognised of the significant work that's been going on, and we have moved in the right direction. So in November, the latest figures are we are only 2% behind trajectory for FDS, and we have made an 8% improvement on patients on the 62-day pathway. So again, moving in the right direction, working with the group operational team. That was all I was going to cover, but happy to take any questions. Thank you, Chair.
Okay, let me come to Natalie and Peter first, particularly on the UEC real-time update, and then we'll open up for comment and questions.
Sorry, I'm pressing the wrong button. Is that working?
Yeah.
Okay, so from a UEC perspective, we obviously at the last board meeting briefed on our winter planning. So across both sites, our winter plans were enacted. Our additional bed capacity opened over on the Broad Green site. Thank you to colleagues for doing that between Christmas and New Year. Going into the Christmas period, we entered with below 90% occupancy across both sites, and that was the lowest bed occupancy in Cheshire and Mersey. So we entered in a much, I suppose, stronger position than we did last year. Both sites are pressured. We have been open for on a few occasions since the new year, but we are managing it across sites and with system partners, and we've got strong escalation processes in place. So we're having daily system calls, including NWAS, social care and community providers. The live position on the sites currently is this week has been very pressured. We need to be open and honest that we are using escalation spaces and corridor care. And as I briefed at ARC yesterday, that is absolutely aligned to our SOPs and safe staffing levels. But obviously it's not the care we wish to be providing to our patients. We are doing everything we can to de-escalate and support the ED as quick as possible. So my summary would be, whilst very pressured, we're definitely maintaining flow through the sites better than we did last year. And I think that's testimony to both sites and system partners and the work that went into the winter planning. The only other thing I want to just highlight, because it has been a long, consistent issue, is we often talk at board around our not meeting criteria to reside position, and we've updated on the progress we've made so far. Last year, when we did our lessons learned from our critical incidents, one of the biggest drivers was the lack of discharges over the Christmas and New Year period and the rise in NMC2R. We haven't seen that rise this year. We've maintained our delayed discharge days, or we've kept them stable as they were pre-Christmas. There are a couple of key interventions happening in the next couple of weeks. So as James mentioned, we have the palliative care bed base coming online next week on the Hearts of Chester and Broad Green site. We have really worked, as I briefed board last week, on moving to 7-day service provision, particularly for those patients to go home with packages of care. And we have 20 slots available this weekend to support Royal and Aintree patients to go home. So that's aligned to our improvement plans. And you'll remember there were circa 50 additional P3 care home beds to be opened in the city, and they are due to start phasing opening those from next week. So Liverpool Council are supporting staffing of those, and we will get the first cohort of beds available from Monday. So there are some further key interventions planned for next week, which I'm hoping will further support sites.
Thanks, that's all. Peter, do you want?
Yeah, so Nat's covered most of it, but just to give some entry specifics. So if you look at the SPC charts, you will see that the last 3 weeks higher than median had an average attendances, both ambulance and walk-in. So as Nat says, the ED has been pressured from attendance perspective. I think in terms of as Nat said, the winter plan has been enacted. There's been 3 key things at entry for us, I think. The first would be the point of care testing in the ED for infection prevention control, and our increased focus on infection prevention control on the wards and fundamentals of care. I think that's allowed us specifically to cope better than the 2 times we've seen this pressure for the entry this year, the end of October and the beginning of December, when we had similarly high attendances from a flu perspective. Those two key changes we focused on have allowed us to cope with those pressures much better entry. The second thing, as Nat said, we have opened some escalation, which was planned in the winter plan, so that does allow us to manage that flow differently. And the third bit, in part of the winter plan, we've talked about the 2 weeks sort of over that Christmas festive New Year period, where both sites really focused on flow, and we had made events and we had discharge focus and really focus on our assessment areas of the BD. So having put those three key interventions in place, I think we entered, certainly from an entry perspective, entered January in a strong position than we did last year, for example. Before our percentage is running around about average for entry currently, as is 12 hours in department. But as a measure of possible green shoots, we in the first 11 days of January, if the ambulance handover time at the entry was 40 minutes, which is much better than it can be and much better than it was last year. So definitely busy, but I think our winter planning has really stood us in good stead this year, and has allowed us to enter January in a better footing, as Matt had said, than we did last year.
David.
Thank you, Chair. Just to come in on this point around health safety, as both Nat and Pete have said, any unfunded areas, whether they be on wards or in corridors, we are staffing them with an agreed new staffing formula, so that we ensure that patients are receiving care. And what we're also doing, and which we have done for some time, is we're monitoring any harms that any patients in those areas are encountering, so that we can learn what impact we're having on patients. The experience we know isn't what we want, but what we don't want to do is be causing additional harms to patients during that time. And so we monitor that at the same point as the length of stay that we have within the organisation.
Thanks, David. Back to Ben.
It was James actually that he's put his hand up, just because you can't see the yellow border on that, can you? So just
Maybe you was the colourblind one. James.
Yeah, just to note the latest national data that we now get every week, which I know you take a keen interest in, Chair, on this. The pressure around the beds and the delay perspective is a good indicator. I think for our performance latest week, we're in the top 20% nationally, which is great. But if you look at the 12-hour, we're in the bottom 25-30%, 84th. Now, if you just look to the Cheshire Mersey data, we're the best performer in Cheshire Mersey on 12 hours. But the whole of Cheshire Mersey is in the bottom of that pack, as is a lot of the Northwest. So sort of relying, I think those national data benchmarks coming out recently do tell a slightly different picture of the usual productivity packs that we see locally in Cheshire Mersey in the Northwest region, because clearly this part of the world isn't performing as well on the 12 hours, which is usually a symptom of admitted bed issues. So whilst we're doing well in C&M, it's still bottom 25-30% nationally, so we need to do more.
Thank you.
Just a query for Beth, actually. On the Liverpool women, it's good to see progress that's been made on the faster diagnostics. Obviously, on the risk register that came up at ARC, it was registered as a risk of 12. And I was just saying, obviously, the target got agreed with NHS England to achieve 78.1 by the end of March. How are you assessing the risk of us achieving that by the end of that period, given the progress that's been made?
So there is regular review of all the constitutional standards, which FDS is one of them. It goes, the governance, it goes through the Hospital Management Board at LWH, and they assess the risk, and that aggregates up to the group risk, which you will see in the SMB papers. So yes, it is regularly reviewed. However, we have kept the risk at 12 for the targets that we're not achieving, given the challenges that we're still encountering in Q4 and getting to the year end. Thank you.
Thanks, Mark.
Thank you. Sure. I just want that it does feel quite different this time this year and last year, which is huge encouragement. So well done to everyone. Can I just raise on this in the report? I probably should have flagged it yesterday, which apologies, but increase in sickness absence and increase in leavers from permanent also within 1 year. Is that cyclical? Is that time of emerging pressure? Some people exiting the base emerging pressure. Is there another explanation for it?
Right. James? Oh, sorry, Natalie.
Sorry, just
Coming in. Sorry.
okay, just on the sickness absence, the data in the pack was the November IPR. That is when you look at the infectious information, that is when we had the peak of the flu. So when we went through the sickness absence, we had an awful lot of short-term sickness. You'll see it's the short-term that rose, related to a lot of it is respiratory condition, short-term absence. So when we saw the December data that had started to come down again, but we obviously have an underlying trend that our sickness absence is above national average, and as we picked up our senior management board this week, that will be a real focus for us, is reducing that sickness absence. So definitely, Mike, an area of focus for us is reducing sickness absence because we are above national average. But November particularly saw a peak in staff absence due to particularly respiratory and flu related.
David next, please.
Thanks, Chair. First of all, just say how pleased I am, Natalie is saying about the extra capacity available in the community to reduce our no criteria to reside patient. It's really encouraging. Forward to seeing the benefits of that coming through. David mentioned the arrangements we're making for corridor care. I have to say again, when I visited the hospitals here and the Royal and visited the A&E departments, I've been really impressed that the staff are caring for the patients. That not ideal arrangements, not ideal location, but I'm really impressed the way the staff are caring and looking after and attentive to those patients. So well done to that as well. My question for Beth was, you mentioned that the A&E numbers at Liverpool Women's have bounced up again in December, which is really encouraging. But is there any learning from it? Do you know what caused the dip in November and what's happened to improve the numbers, or is it just cyclical? Thank you.
Okay, thank you. There were operational factors affecting that performance, and one of them being sickness actually in the November. So that's why you've seen the recovery in December. So it was short-term operational issues that were being experienced at the women's, but that's why the recovery. Yes, is that right, Jen? I see you, but yes, that's what I've been told.
Thank you.
Jeffrey, please.
Thanks, Joe. On the Today programme this morning, the Secretary of State was on, and they were discussing the normalisation of corridor care as it's crept across the system. And I took assurance yesterday at the ARC about how we're measuring how much time actually people spend in the corridor, the safe and staffing levels, the safe and well checks, the pain checks, all the rest of it. I also got a very good initiative where you swap the patients who are medically fit for discharge to the corridor for those that clearly need an acute bed, because it's always about mitigating the risk for the patients. So I took assurance yesterday from that information. I think they're going to continue to measure how long people stay. But it's clearly not unique to us. It's a system-wide issue. And it's not what we want our patients to be. What I always worry about in corridor care is how cold patients can get. Because they're often drafty places, making sure they're kept warm all the time. But I know that you have those measures in place, and I do take assurance from that.
Thanks.
Thank you.
Tom.
On a different note, I was impressed by the gradual fall in our waiting list, and I wanted to be sure that reflected increased activity on our part rather than reduction in referrals. But it looked very impressive at first glance, so I'm interested in explanations for that, if we can, and how we benchmark nationally. But I'm also concerned all the time, we still have this ongoing issue around theatre utilisation. We don't seem to be able to get that correct. It's improving slowly, but it's not really sorted at any point. So I'd be interested in your comments on both of those.
Okay, so I'll work back. So first of all, theatre utilisation. We have seen a little bit of a plateau on that. So I acknowledge what you've just said, Tom. What we are going to do though, we are going to work with the sites. So these site improvement plans, they've been working on them throughout the year, and I don't think we're getting the traction that we need for theatre utilisation. So my team is going to be working with the directors of ops at site to see how we can best support that step change this year. So that's one thing, and we need to have that in place by the 1st of April. So those plans are currently, and those discussions are currently ongoing. Secondly, the second question was waiting list. We have done an incredible amount of work on our waiting list. That is real. That reduction, it's been sustained, and that's been as a result of one, validation, ongoing validation. It has been as a result of treating more patients and the additional capacity in some of our specialties. But I also just want to note that it's also about keeping our waiting list as cleansed as possible. We are one of very few hospitals who have an admin academy, of which we've trained over 2,000 of our staff. So again, that validation, unfortunately, is a retrospective look at what's on our waiting list. But I think we are also, as a result of training people, cleansing the waiting list as we go along. So that's also been an important factor in that waiting list reduction. So it's multifactorial, but it is all real and has been sustained.
Thank you. That's good. Thanks, everyone. So I think in performance terms, I mean, Daniel highlighted the issue about trajectories through till the end of the year. I think, James, at the next ARC meeting, if we can look in, the formatting of this cover report was very good with where we're at on the 17th. If we can go at next ARC on an update on the recovery trajectories across all, particularly on the elective, so we can see where we're heading to for the end of March. Any late interventions?
David, may I just ask a quick question?
Sorry, just mid-sentence there, Stu, but
Sorry, beg your pardon. Sorry, beg your pardon. Right. Sorry, I just want to pick up a point on that. Be there about 4:1 activity, elective performance activity, 4:4. Yesterday we had a bit of a mixed message, didn't we, in terms of accelerating activity in 4:4, especially in terms of region and national. Just wondered whether we had any clarity on that. I know it's only been a day, but obviously we need to sort of gear ourselves up for, the expectations are. Just wondered whether there was any further news. Sorry.
that's fine.
So no, we've had no confirmation that we're to proceed with the plans. The plans were submitted, as I said, by 5 o'clock on Monday. But what I will say is we have profiled our delivery of the required targets by the last week in January, February and March. So we have taken into account there may be a lead in time by the time we get the decision. But I think that we will be able to mobilise that quite quickly. We are working with the teams anyway now on what specialties that we will target to deliver the required standards. So we will have those plans in place. So we're working behind the scenes until we get that final decision.
Okay,
Thank you.
Thanks, Sue. No, it's an important question. I'm pleased you raised it. Right. So we tee up for more detail looking at some of these issues at the next meeting, and we'll keep on top of the non-elected. But as I say, so far so good with all of that. Well done to everybody. Now we have Rob's finance update. After the meeting in public, we come into a more private session, which is all about financial position for the remainder of this year and planning for next year and indeed beyond. So we need to receive the report till the end of November now, but I propose if board members are content, then that we pick up the discussion and any further questions and concerns in the meeting later, if that's okay.
Thank you, Chair. So I'll take the paper as read, detailed the finances, which draw out the month 8 position in summary. The good news is that at month 8, excluding deficit support funding, the group as a whole was on track. In fact, it was £200,000 above plan. The overall position was a £57.9 million deficit, constructed of 46.4 million at Love, 17.2 million deficit at Liverpool Women's, and a surplus at Liverpool Heart and Chest at £5.7 million. I mention the deficit support funding because it's important to remember that at the start of the year, deficits, a system agreed plan was agreed and put forward to NHS for a deficit of 178 million, of which was agreed to be met, agreed to be supported by deficit support funding. However, that deficit support funding is subject to release by the region based on the confidence of delivery of plan. Therefore, although the system received deficit support funding in Q1, however, in quarters 2 and 3, that money has been withheld, subject to a surety on the overall system plan. That is a significant number for Luft and Liverpool Women's, with the total annual amount of £44.5 million for Luft and 15.3 million for Liverpool Women's. That equates to 3.7 million a month and just under 1.3 million a month for Luft and Liverpool Women's, respectively. Therefore, at month 8, we have had withheld 5 months worth of deficit support funding, and that is the variance you see in the plan. So that's 18.5 million for Luft and 6.4 million for Liverpool. So it's just important to remind ourselves of that. There is still the possibility to retrospectively earn deficit support funding or for it to be released. However, at this point in time, that's not been released, and there's a continuation of that deficit support funding being withheld. In terms of other key metrics, the CIP you can see is significant. Overall, at the group, we've achieved £77.4 million worth of cost improvement plans, which is ahead of plan by 4.6 million. Again, that's constructed through 62.5 at Luft, 7.9 million at Liverpool Women's, and 5.7 million at Liverpool Heart and Chest. So significant effort across the group. However, it is recognised that not all of that is recurrent, and running at just shy of 50% up to 70% of recurrency does store for us a
an issue going into the following years. We do have significant opportunities and schemes identified above plan. So everyone's working hard on those, but we take a risk assessed view on whether those hard to deliver schemes will impact in the final quarter of the year, and that goes into our final forecast that I'll talk about shortly. In terms of the run rate across the group, pleased to say Liverpool Women's and Liverpool Heart and Chest are on plan versus the average required. In terms of Love, we are £4.3 million away from the average required on a monthly basis. The key driver there is pay. It's offset somewhat by income, but we're just short of just above £5.5 million a month away from where we need to be on a run rate basis. So significant work to do in that area, as we've talked about many times. We do an assessment of risk existing in the plans, and not least going into the final quarter with winter and a restricted resource that we reserved for winter. No additional monies were made available or are expected for winter. And in terms of the forecast at the end of the year, we look at that on an assessment of best case, mid case being the likely case, and downside possibilities. For both Liverpool Heart and Chest and Liverpool Women's, we are assessing the likely forecast to hit plan by the end of the year. For Luft, as at month 8, there will be a shortfall of £21.1 million. We'll talk about month 9 later, and we have seen some shoots of recovery in month 9, and we continue to be on plan at month 9 across the group, Chair, pleased to say, but we'll go into more detail later. The only other point to note is the cash position, and you can see that that remains tight, particularly across Luft and Liverpool Women's, where at the end of month 8 we had one operating day's worth of cash. It is the lowest point in the cycle, and we get paid at the start of the month, but nevertheless what that requires is that we apply for distressed cash funding for both organisations, and we've done that. There's a robust process that we go through with NHS on a monthly basis for that. That is directly impacted by the withheld cash for deficit support. Happy to take any questions.
That's okay. So, thank you, Rob. Are there any urgent questions? So we have a broad and deep discussion on all of this later today, which moves forward from where we were in this report. Thank you. Right. Now, I'm on the time for someone to give me an affirmative nod. I'm right on the right time now for the lunch break, 20-minute break. We do a lot of things very well in this board. One of the things we don't do well is stick to the allocated time for next. So particularly important today because I have a bit of time to make up in the second part of the meeting. So if we could break now and be sat down ready to listen to business at 13:40, be greatly appreciated.
No, it's sounding just not here.
No,
into some of the governance papers, and Daniel will steer us through this next part of the agenda.
The first one is in relation to, we have the assurance report from the Strategy and Partnerships Committee, which met in November. There are no areas of escalation on the board. The report highlights some of the issues discussed. Just wanted to highlight, obviously, we've received updates on the development of the strategy that was referenced earlier by James. We also had a deep dive in terms of the discharge improvement plans, digital information, and details of some of the partnership arrangements, especially covering the partnership governance that we've got in place between Liverpool Women's and Alder Hay around neonatal partnerships. So I haven't taken any questions in relation to the strategy and partnership. Okay, the next bit's in terms of governance. There's two bits, obviously, in terms of the corporate governance manual for the group. We're proposing two changes that we require board approval for. In relation to the Assurance and Risk Committee, we obviously, as part of the expansion of the group arrangements to include Liverpool NHS, we've changed the terms of reference for that committee to include membership from Liverpool Heart and Chest. And in relation to the Strategy and Partnerships Committee, again, made the same amendments in relation to the inclusion of Heart and Chest. But obviously, as members will be aware, we are proposing to introduce a new strategic partnership group, which will be reporting through to that committee going forward. So subject to any comments today, we're seeking approval from board members.
Thank you. Everyone can say. Thank you.
We're just now turning to the various organisations, statutory governance that we have to do. The first update is from the Audit Committee, David.
Thanks, Chair. I'll take the paper that's with the pack as read. The Audit Committee that met on the 4th of December. We did also have an Audit Committee meeting yesterday, where we received 5 MIA internal audit reports, 4 of which gave us substantial assurance, so we were really pleased with that. We recognise that the internal audit plan is a bit behind where we would like to be, and we think there's some learning from that in that we set the timescale for some of these audits a bit optimistically. But we hope to be back near to plan when we next meet on the 26th of February. We also did a deep dive into the PwC grip and control processes, and Rob and executive colleagues took us through that, and we were very assured about the level of work that's gone on in putting systems and processes in place to deliver the things identified in the grip and control report. Finally, I should mention that our external auditor mentioned that there's going to be a rotation of our external auditor. Sarah will be stepping away from the audit going forward. She becomes time barred because she's been doing the LUF audit for so long. And Liz Luddington, who many of us will know is the external auditor at the Women's and at Heart and Chest, will take over the LUF audit as well, which I think has to be a good thing because it brings some coordination for the group audits. So that, I think, is a summary of business. Yes, Chair. Thank you.
Thanks. If there was good assurance on 4 of the internal audit reports, what was the 5th report? What was the assurance from?
For testing me there, Chair.
Okay, I'll come back to you in a bit.
Thank you.
Thank you.
Yeah, thanks, Chair. The other details, obviously, details of the LUF Transport Funds Committee, where we've got an independent chair. Obviously, Chris, is there anything that you wanted to highlight?
Thanks. Just very briefly, the technical report is read. I think I just wanted to draw out about the point of care ultrasound piece of work that we've been doing with renal, just as a kind of taking colleagues back to a discussion we had at Strategy and Partnerships around how we want to focus our charitable activities a bit more. I think it's just a really good example of where we're demonstrating kind of investment that supports improvements in quality and patient experience, And I think how it supports some of the kind of activity we talked about a little earlier around managing pressures through the system in terms of supporting discharge and kind of emission avoidance. So I think it was just a really good example about how we can invest in areas and activities that we might not be able to do day to day, and support kind of new practice and kind of investment moving forward in some of our clinical areas. So just wanted to draw that out. Thanks for your
Thanks, Chris. We're moving on to the Liverpool NHS, and again, details are in the pack about the audit committee that we had in November. We've had another audit committee this week. So, David, was there anything?
Just to highlight again, 3 audit reports received from MIA colleagues, all gave substantial assurance, which is good.
Also in the pack today, we've got details of the Liverpool NHS Charitable Funds Committee, the October meeting, and again, we have a Charitable Funds Committee for the Liverpool NHS this week. I don't think there was any areas of escalation.
I think it's worth mentioning. It's worth mentioning that because of unforeseen circumstances that the Chair mentioned in his introduction, the meeting wasn't quorum on Monday. There were several decisions that needed to be made, and we agreed that we will make those decisions in exchange of emails with committee members. But no significant points to update on there.
Did you spend any money?
We didn't spend any money. There were a couple of proposals, one of which the Sim Centre, it requires a big investment, but we weren't ready to make a decision on that. We'll be making a decision on that when we meet at our next meeting, which I think, Daniel correctly, is on the 10th of March.
No statutory separate committees for Liverpool Women's. There's a range of them in the next fortnight, and obviously we'll provide updates of that at the next public board.
Thanks, Tom. Okay. His update report earlier, James mentioned about North Mersey work that we do in partnership with Alder Hay and with Mersey Care, referenced this memorandum of understanding, which our approval is sought. Tom, do you want to set this out for us, please?
Yes, certainly. Second. So thank you. So as James mentioned earlier, this is the partnership with the University Hospital of Liverpool Group with Alder Hay and Mersey Care. It's been in existence since late 2024. So the MOU has been worked on over the last couple of months, looking to formalise that partnership. So MOU, it's obviously non-binding, but it sets out the commitment of the partners in terms of principles of partnership working, the scope of the partnership, and some of the governance as well. So the proposal is that this is going to the other 2 sets of boards of directors over the coming weeks with the same cover paper as you have in the pack. When it comes to principles, you'll see themes there around committing to work to the interests of the population, to share data, manage risks collectively, and work through collaboration rather than competition. When it comes to scope, I think it's fair to say that the genesis of the partnership was around integrating the community providers, but actually recent actions have shown that there's clear potential to work together on things like research, innovation, commercial partnerships as well. So that's included in the MOU. And then governance-wise, the partnerships overseen by an executive group. Terms of reference are appended to the MOU in the pack. So yes, as you said, Chair, the board's asked to note, review and comment, and if appropriate, approve the MOU.
Thank you. This is really good work, important work for us in working with both Alder Hay and Mersey Care. There's a change in chair, the board at Mersey Care. Rosie's did a lot of work with us. is leaving, and David Fillingham, who we know him from different roles over the years, has taken up the reins there on a time-defined period. I can't remember exactly what it is, but I'm meeting him next week anyway, so we look forward to continuing to build our productive relationship. Any points, questions, concerns, please, for Tom about the approval of this MOU? Everyone content? Yeah. Thank you very much. Well done, Tom. Approved. Right. Let's move into the quality and safety segment of the agenda, please. And we start with the maternity and neonatal system and the MIS. David.
Thank you, Chair. I'd invite my colleague Helen Jones, the Interim Director of Midwifery, who's in attendance for today's item. I'd also like to welcome colleagues from the local maternity and neonatal system who are in attendance in the public area today. Thank you. Colleagues are already familiar with this paper because it's been presented on different occasions previously. And this is for the board to seek assurance from the documents and to agree to sign off the documents so that we can make a full declaration sometime before the 3rd of March so that we can demonstrate our compliance. There is a lot of information behind the levels of compliance that are identified within the areas of the 10 safety actions. But there is just one I would like to bring to the attention of the group, and that's safety action number 7, where there were some previous questions, and that was predominantly around were we able to provide assurance around the engagement, involvement and co-production of feedback from people who use the service, predominantly using colleagues from the Maternity and Neonatal Voices Partnership. And so whilst we were sure that we were doing that, I think that the ability to be able to demonstrate that previously was less than it should have been. However, there's been a lot of work carried out to ensure that the governance around that is stronger. There's greater evidence of the processes that we are taking, the engagement opportunities, as well as looking at things like the terms of reference and the scheme of governance within the local sites. Importantly, the use of the information derived from those patient feedback opportunities is now being used a lot more effectively and is being shared not just around our own organisations, but wider system colleagues also. There is assurance also around the action plan that's co-produced using CQC model of co-production as well. That's the summary of this paper. I'm happy to take any questions, but anything technical, I will defer to my colleague across the table. Thank you.
Thank you. Thanks very much for coming, Hans. Do you want to add before I open up?
No, I think it's a collaboration with well as a team, as a perinatal team, and we're advancing all the time. So it seemed to be this year that it was a more seamless kind of process. And I would like to thank our LMNS colleagues because they provided that very valuable assurance and fresh eye approach to ensure that we are on the correct pathway and also for them have the project community.
Thank you. Point, question, observation. I miss Jackie at this moment. Jackie Bird normally takes, because we're expert knowledge and history normally takes the lead. I wonder if we can put a loop in place that has Jackie seen this signed off?
She has, and I spoke with Jackie yesterday, not fundamentally about this paper, but before she received the news about the issue why she couldn't come to board. And she was actually in the Liverpool Women's Hospital yesterday, was conducting a maternity champion walkabout yesterday.
Okay, so she's
cited on this.
She's cited on this, and
there was no issue she was going to. She told me she was going to.
Okay, Jeffrey, please.
Before Christmas, I did a joint government engagement visit at the neonatal unit, and it was absolutely inspirational. Fantastic atmosphere, great team working, good staff morale, and the joint working do to the whole ahead. Really, really good. So, very good example. So, this is just fulfilling another element of assurance, really.
Thank you. Daniel, please.
Yeah, just first of all, amazing achievement. So what I did on this was just go back on and look at the last 3 reports that we've received. So it was really good to see the continued progress that's been making. You can see the whole book. One question I was going to have is, even though we're compliant on standard around seeking parents' view and care, or even though we've achieved more than 95%, I just wanted to know, in previous reports, it said how many families this related to. And obviously, in previous reports, we've reported 100% compliance. And I noticed compliance had gone down. I didn't know how many families this related to, and were there any circumstances or local do for why that standard suddenly dropped ever so slightly?
No, I think it's the amount of the questionnaires go out. And I think one thing that is a challenge is to continuously try and achieve more kind of women so that we obtain that feedback. And that's why we work very closely with our maternity and neonatal voices partnership. We have a chair and a deputy chair, and they are very recent service users. So they very regularly go to the local areas to seek that feedback so that we're getting that very real time feedback. So that's work that we're ongoing.
Thank you. As colleagues have said, the green ratings across the board are very impressive. And this is a service that's constantly, national level, constantly on scrutiny in the public eye. It's a very, very impressive report. James, if we make the board declaration in support of this, you're the signatory to it. You can content for us to seek board approval now.
I am. I had a very quick question, if I may, Chair.
Yeah, of course. Sorry.
It was just on the training elements on SA8. Clearly, when we last talked about this, there was an issue with the consultant obstetrician numbers, and that suddenly has improved massively in November, which is great. But I just wanted to seek some assurance around the sustainability of that. Has that been sort of corralling everyone together as a one-off, or have we got something more systematic in training now to make sure that sits above the 95%?
Absolutely, thank you. So each lead, each safety action does have a lead. We meet on a fortnightly basis to allow that lead to escalate any concerns they may have so that we can work collaboratively again to make sure that we always maintain that trajectory, or if there are any issues that crop up, that we can put in some actions. So for year 8, which we are anticipating the MIS scheme, then we will continue with those fortnightly meetings so that we're working towards it as a team rather than people in isolation, so that all members are feeling supported.
Thanks, Alice. And well done. It's a brilliant report again. Yeah, on the basis, Chair, that the obviously the Liverpool Women's Hospital Management Board discussed this at length and went through this in lots of detail with our LMS colleagues present, I believe, as well. I spoke to Jenny about this the other week just to get her take on that discussion and where they felt this had got to. Again, I think it's a really good report and really good performance. So it's been very heavily scrutinised through the LWH governance process. It's been here. Like you, I would have preferred it if Jackie was here just to get the nod from Jackie as the board maternity safety champion, but I know she's aware of it. So yeah, I'm very happy to sign it off on the basis of the assurance I've already received.
Thank you. So, all consent to approve the declaration, please.
Yes.
Thank you. Thank you very much for covering a lot. It's good to see you. The learning from Dad's quarterly report, few watching.
Thank you, Jack. So I've done a cover paper here because we've got essentially 3 reports, one from LUC, one from Liverpool Heart and Chest, and one from Liverpool Women's, and they're all distinctly different. I think for any of us thinking about statistics, the more data points you've got, the better. So when we're thinking about a quarter report for LUC, we're talking about 1,000 deaths. When we're talking about Heart and Chest, we're talking about 50. And then we're seeing a very different data set in terms of neonatal mortality and stillbirths from Liverpool. So they're very different. We're using different statistical modelling in them. So we need to be aware of that. In LUF, I think the key points are the shimmy, Sunday hospital mortality indices, and the HSMR, hospital standardised mortality ratio, stay well within the normal limits, and there are a lot of data points, so I think that's quite low. Liverpool Heart and Chest uses the standardised mortality ratios, which are appropriate to the case mix of a tertiary cardiac centre. A lot of thought gone into that, so we're looking at something different. What SMR doesn't do is look at deaths post-discharge. So HSMSR and Shinny are looking at 30 days post-discharge as well. So we've got very different areas of inquiry. And then, of course, there are all the data reports that come out of. So just to be clear, we're talking about quite different things. What I'm planning to do as far as adult deaths is concerned in the coming quarters is to bring them more together. But these reports have worked well for the member trust, so I don't think we need to alter them drastically so long as you will get sufficient assurance from them. In terms of learning from Luft, we've picked up the theme around palliative care, and it's which is something I've talked about a lot in this group before, about end-of-life care in busy district general hospitals and bed provision. So the opening of the new beds from next week at Broad Green is really to be celebrated in that context. The more, the better, from my point of view, in terms of learning that's and obviously the balance to be struck. I think we're driving towards 10 beds in the first instance. So that's some real learning out of that. In the adult report, you'll see we're always looking for, are there some subsets? Is there something going on in the system where there's a trend developing and so forth? And when we see that through the cumulative sum stats, we will go and look at coding and so forth. And I've reported back on various issues before. And we're doing that at the moment around biliary disease. In fact, we've looked there before, haven't we? And we still can't see that there's anything materially wrong as far as we can tell, but we need to be looking. And I think the learning from the adult reports, there's a bit more this time around antibiotics. I think this board, we will need to pay attention to antimicrobial stewardship over the coming months. So I think there's a signal coming actually about that. The other thing that report's saying is that our structures, we're doing what the commissioners have asked us to do in terms of number of reviews and so forth. So just looking at heart and chest, what I think we see in heart and chest report is some very, very detailed scrutiny of all of the deaths occurring there and highly skilled tertiary professional groups having intellectual discussions about quite fine detail in terms of the manual, which is fabulous. That's what we would want our tertiary centres to do. And so when I look at that and see them saying, well, maybe we could have had a better outcome here, I think we should be able to give real reassurance to our patients that what we're talking about are very intellectual discussions about patients who are extremely poorly coming to have, very, very sharp-end interventions. So maybe something could have happened differently, but my interpretation of that is fair play, but we're talking about things that are very, very complicated. And then when we look at the Liverpool Women's Report, I think this quarter's report, fundamentally, we're looking at data here and showing that the data is within normal limits. There are some learning points, and there's an interesting case between Liverpool Women's and Aintree, which you will see referenced, where a pregnant lady passed away in our intensive care in Aintree, but Liverpool Women's colleagues were involved. And actually, I think it's honest to say that a positive outcome of our group arrangement was it was much easier to get everybody together to do the review. And indeed to produce some recommendations, which in this case would largely be to support our medical examiners with some more obstetric expertise in very complicated cases like this. So I think I've put all of the site reports behind the cover paper, but Chair, I hope that feels to you like a fair summary where I think we're the sweet.
Just Jim. Which questions, please? Anything, Jonathan, you wanted to add?
It'd be wrong to take the three reports
collectively because they are very different in the arrangements. And we had this discussion in both our HMB and our HLT meetings to make sure that when we were looking at the robust review of debts, where there are elements where it says potential of avoidable, that it's understood in that kind of context.
Jenny, anything you want to add? Okay, Mike.
Thanks, Liv. I think those are really good reports. I think they do read contextually appropriately, so that's really helpful. Just a couple of comments. One on the PMR KPIs, where the global total is 5. There are some hotspot areas that could mask concerns. So if I'm thinking like respiratory, sanctuary or general surgery, are we following up those hotspot areas? And then secondly, in terms of the women's and the stillbirth stuff, so 3.9 out of 1,000 is within expected limits, but is it within acceptable limits, and just the disparity between that and expected?
Thank you, Mike. So the first one is I like showing that data at departmental level because it calls it out, so there's nowhere to hide there. So the answer is yes. So our Associate Medical Director for Patient Safety follows it. The standard excuse, of course, is to do with workload, and there's I have some sympathy for that, but it is a requirement, so we keep working on that. I'd actually make a little bit of a link to the job planning policy, actually, where we're pushing to make sure they do what we think they should do in their SPA time. And so we'll keep doing that. And then, yes, reference to the stats, as you say, you can see the trajectory, which is going in the right direction. But yes, it's outside the hoped for target. It has been for a long time, hasn't it? I wondered whether we might maybe get Chris to come and talk to us a bit more about that next time. Because we assumed, don't we, that a lot of that is to do with external factors beyond our control. So can we reach out or can we engage more in the community settings, which is, of course, what we're trying to do in some of the initiatives that we just talked about.
Okay. Yeah, I think that what you suggest would be helpful, Jim. But picture. Pete's next.
Yeah, it's just to add to Jim's response to Mike's question, because it is an absolutely correct question, and I do bring this up at our HMB as well, Mike, just to give assurance. And respiratory have been on a bit of a up and down trajectory with this. If you look back at the previous February, they were okay, and then for that they weren't. So I think it's job planning, but Becky's definitely on that, and with that performance needs to improve. It really drives, I think, the overall performance. There's other areas that have improved following some of that type of targeted intervention, so we'll carry on with
that. Tom, next, please. Thank you. You mentioned biliary disease as an outlier. Does that really take account of the fact that we're basically a tertiary care centre for this? And you've made a case, for instance, for Royal Green or Heart and Chest being quite different because it is a tertiary care centre. Does your comparator allow for that in biliary disease?
Tom, thank you. The stats in that sense is quite a blunt instrument, isn't it? And I think it possibly does is probably the best answer I can give you there, because you see some quite complicated coding. You've got to put a primary code in, so it might be biliary disease, but there could be a hepatic cancer sitting behind that or something. So I think you're probably right, but it's coming up as a signal, so we need to look. That's the purpose of it. Thank you.
Sue next.
Thank you, David. Just a couple of points. Just with regard to the unavoidable death and the involvement of the coroner in those, I wanted to understand a bit more about families, reactions to those situations, and whether there's anything we need to know about the board in regards to those 2 points. And also, the second point is around learning from deaths generally. So this is a great report, really informative. But how do we embed the lessons within the organisation from these reports?
Yeah, thank you, Sue. So the first question relates mostly to Liverpool Women's, I think, against that. And of course, they have their bereavement team specifically. Now, there was an acronym which I had to check. Just check for you, There's all sorts of nice names. That's called the Honeysuckle team, isn't it? And so there are very good systems I can see at Liverpool following. Actually, we've talked before about some learning that love was around the introduction of the Swan team and development of that in terms of bereavement support. I think I think it's got a lot better, a lot more comprehensive in the last few years. And of course, because we now have medical examiners for every single death, there is a connection to the family right at the moment of death of someone who is essentially removed from that piece. So they are more clearly objective, one might say. And I think that's shown to be a benefit in terms of support to families. So there are both our own, if you like, internal systems at each one of the sites, and then there is the medical examiners process as well. If families find themselves needing to go to the coroner's court, then the support goes with them. And it's important to remember as well that that's a pretty stressful moment for clinicians. So in each of the sites, we've got extra support, psychology support, and so on for them as well.
Okay, and in terms of the lessons from deaths being embedded.
Right, well, they're different on each side. And I suppose I tend to pull out some things. Of course, we've got the patient safety newsletter for Love, which is produced every month. That always has learning from the cases. That's going right across the trust. The mortality governance groups exist at each site. So they're bringing these secondary reviews in and discussing it, and then feeding them back through the mortality and morbidity meetings. And I accept the kind of challenge because it's a little bit hard to measure all of it. But I think one can see evidence through the way the system works, so that we are seeing people reflecting on these issues and developing.
Yeah, and we've talked in the past about reporting some of the data on mortality with regards to ethnicity and disability. I'm sort of getting a bit more sort of information on that. So
yeah, I think that's a very good challenge. That there are more requirements from NHS England now in terms of reporting. Art Powler, our consultant in public health, is very interested to look at that, and we're actually working with Matt's business intelligence teams to try and pull out more and more of that information. I think we would say at the moment it's not as well developed as it could be. So it's a good line of inquiry. We put deprivation data in. Quite difficult to get it each time, but I think it's good to do it. So I'm very happy to pick up on that challenge.
Okay, thank you.
Thank you. Are we content to receive the report in the short time? Thank you, Jim. Well done.
Thank you.
We now got the Liverpool Heart and Chest Control Drugs report, please.
Oh, yeah, thank you. So it's a requirement of the various legal acts around controlled drugs that there's an annual report. And this is the annual report for Liverpool Heart and Chest, which is a statutory body in its own right. I brought the report for Luff and Liverpool Women's in November, I think, Chair. Yeah. And that's because, well, Pippa Roberts is the CDAO for both, indeed the chief pharmacist for both. So Danny Forrest wrote this report. He's the chief pharmacist for Liverpool Heart and Chest. I think it's a very clear report. He clarifies the legal requirements. Heart and Chest is also provides controlled drugs to other institutions, so it needs a Home Office license specifically for that as well. And you'll see in the paper that there was a review of the arrangements there, which highlighted some concerns around security issues, which have been properly dealt with, and Danny gives us assurance that that is the case. All incidents are reported to the local intelligence network. And I think what you see in this report, what I take from it partly is that it's a very good system of based pharmacy at the NHS, which gives good assurance in terms of grip and control. There's a very interesting closed loop system for CDs, which is something I'm sure we will aspire to procure a new electronic patient record, because it makes the system much more reliable. It removes some human factors which are often a problem in busy wards. So I hope, Chair, you agree there's a lot of assurances. I'd like to note it.
Thank you. Any questions or concerns anyone wishes to raise? Jonathan, you've a longer history with us on this. Are you?
Yeah,
tell me where
we went through this in our hospital management board a couple of weeks ago, and Danny is probably most diligent and hardworking from in getting to these reports. So thank you. I'm more than happy to know.
Thank you. We can turn them please to receive the report. No, thank you very much. Right, thanks, Jim. Liverpool Heart and Chest Hospital Infection Prevention and Control report. Please.
Thank you very much, Chair. So just to be aware that this report was, this annual report was written and presented to the Liverpool Heart and Chest Board, obviously prior to joining the group, but for completeness, because I've already presented the other two reports for Liverpool Women's and Luft, we thought it was wise to bring it through here. And so the report actually went through the quality standards group at the beginning of December as well. So it's gone through our governance process. The report itself is contained within the information pack pertaining to today's meeting for scrutiny. However, there are some really important points to bring out. The report is really written against the 51 national standards, of which there's full compliance against all but 3, and 3 that aren't do have a partial compliance. And within the document itself, there's a very clear improvement plan that demonstrates the items, the issues that need to just be continued to improve upon. I won't go through all of the details. However, there are some really important things that we as a group need to acknowledge, that there are some great learning points from all organisations within the group, and not more so than Liverpool Heart and Chest, about some of the techniques, processes and governance to ensure that the issue around healthcare associated infections are managed in a timely and appropriate way. There is evidence of an extensive audit and education and training programme within Liverpool Heart and Chest that I know that we'll be borrowing with confidence across the group to ensure that they have a much more standardised approach in the future. That was really the main issue I wanted to bring out, that this report in the future for the whole of the group come with or 3 reports together. We'll have a more synchronised approach for their delivery within the year, and so that we're not doing the increases we have this time.
Thanks, David. Any point concerns? Very clear report. Thank you. Group safe staffing 6 months.
So, as is the tradition now, we are bringing the 3 reports this time for safe staffing together, and I've produced just one cover sheet, summarises the amount of the detail within those very long and detailed reports that are all contained within the information pack. This is the first time that we brought all 3 safe staffing reports together at the one time to the board. In future, what we'll ensure is that the statutory reports follow a similar template of presentation. There isn't a national template, and so each organisation across the country has already developed their own. But for ease of comparing data, we'll try and have a greater simplicity in our approach. It's really important to note that each of the organisations uses a credible and clearly identified tool to monitor and identify their safe staffing, and that was a requirement of the National Quality Board when this process was initiated, I think back in 2012. Because of the different types of patients we have in the different areas, we use different tools. The SNCT, the Safe Nursing Toolkit, is used across all the organisations. Obviously, maternity services also, and we've spoken about that in previous board meetings, as well as the BAPEM safer staffing tool for neonatal. There are some what I've pulled out is some just key issues in the three organisations. I'll start with Luft. Whilst we have done the 6 monthly review, and there isn't an overall requirement for us to change the staffing establishment for the organisation, as services have changed and there has been some difference in patient populations and patient admissions, there is some need for some staff to, some wards have a higher or a lower establishment requirements, and so there's some minor change to that. However, there are about 4 or 5 areas within Luft that we are conducting a much clearer, deeper dive into the work and the profile of those wards, not because they haven't completed the tool properly, but because there has been a difference in some of the presentation of patients that are now being cared for. That could be that those patients require a greater number of members of staff to support them at any one point. We know the issue of patients in Luft who are admitted with a mental health condition that require them to have a greater number of support staff with them 24 hours a day. And that is becoming more of a feature within some of our clinical areas. And so to ensure that we have a more consistent staffing approach, we are doing a deeper dive into those areas. For the emergency department position, previously when we've looked at some of the work with our staffing requirements has been a little bit misaligned, but thankfully the work that's been happening over the past 12 months shows that that is now in normal alignment. That doesn't mean to say the staff aren't incredibly busy, and when we have extra capacity, we don't require any other staff. But this staffing review is for our normal activity funded beds, not the additional capacity. Liverpool Women's Hospital, in a previous birth rate plus audit in March of last year, there was an identification that they were short of just over 15 whole-time equivalent registered midwives, mainly in specialist and some of the management roles. These posts have now been funded and have now been filled and appointed to. So that was one of the benefits to use a recognised staffing tool, so we know that we are commensurate with national guidance. And again, there was issues within the neonatal services to ensure that we needed to have not just the safe staffing numbers, but who are appropriately trained to look after those very dependent babies. And again, that is that's in train and it is now compliant. Liverpool Heart and Chest Hospital, one of the issues there that we've really focused upon is the size of the critical care area at Liverpool Heart and Chest, using the TPICS safe staffing tool that demonstrated the funded establishments were appropriate to meet the clinical and acuity requirements of the service. And again, one of the benefits of doing a longitudinal study like this is we can pick up over a number of years around any changes to that requirement for the workforce, not just in the numbers, but also in the skills that are required. So I asked board to receive the papers, receive the reports, and I'm happy to provide any further assurance before we conclude business.
Thanks, David. When we talked in Rob's update earlier, we'll talk again later today about tracking headcount and pay budgets and overspend and so on. This is really important part of that discussion. And as a board, it's about trying to find the right balance and the right place to land our judgments with these things. And it's important that we do both side by side, not do them separately or only do one side of that discussion. Sorry, David.
Sorry, just to add to that, thank you, Chair, for jogging something that I should have included in the summary. We are just concluding the last month of the rollout of the Safe Care tool, which is an acuity tool that measures live acuity across luft of the patients that are within our bed base. That gives us a much greater live experience of where the greatest need for support for patients is. And so we can have a more mobile workforce to deal with that rather than immediately deferring to requiring additional nursing requirements. That will always be the case, but we need to make sure our own resources are used wisely first.
Yes, absolutely. It doesn't change anything in terms of our termination and requirement to be more productive and efficient and all of those
Indeed.
things. But it,
and a greater level of governance so that we can assure that all are using public advice.
Thank you. Mike.
Thank you. Jim, can I borrow the machine again? Yeah, thanks, Dave. It does read as a real life, real time tool, which is great to see. But just on David's point, I'm just a bit confused in terms of spend. So it says sustained reduction in bank spend of a certain amount. It's on page 5. And then increase in agency spend. And the increase in agency spend by my maths is greater than the reduction in bank spend. And so that might be the right thing to do, but I think we're just in danger of fixing on one line to say reduction good, and actually the aggregate may well be an increase.
I will be diplomatic in how I respond to this. There was Cheshire and Merseyside requirements that the bank pay rates for registered nurses or anyone over a band 5 were moved from top increments payment to midpoint. And that was a recognised consequence for some areas, that some of those more experienced staff would not pick up bank shifts because they would be getting less to do an extra shift than they would in their substantive shift. And we recognise that, and that's one of the issues that we are looking at around, is that something that's going to cause us a longer term issue, A, with staffing and staff experience, but also financially? And if that is the case, would we take a more local action around some areas having an enhanced rate? And that's the figures that we're looking at currently. We only enacted that in the summer.
Thank you. Yes, Natalie.
It was just on the agency point, so just to give some side context as well from a royal perspective, Mike, the agency is largely in 2 areas. It's to support the emergency department where we have escalations of costs and we're responding to demand, so we're needing to put additional staff in, and the other is critical care where we need a different skill set and we may struggle to get that off the bank, so we go to the agency. But again, this is all part of our weekly grip and control review that we undertake. So
thank you. I've got Rob and Peter.
Yeah, and just to support, so I think it is a significant area of spend financially, but the commitment to maintaining within 100% of fill rates is really important. I think the quantum is significantly different, Mike. So if we look at, this is month 1 to 9, bank spend year to date is around £45 million. And that's a reduction of 1.7 million year on year for the same period. Agency spend is 7.3 million. So there's a quantum of difference, and that's compared to 8.6 million from the year before. So overall, year on year, those 2 items are £3 million lower, and we continue to work together. I think this the safe care tool will be a significant benefit of moving staff around.
The report doesn't say that.
No,
yeah.
Thank you. Peter.
Yeah, it's just really to give the same update as Nat gave from an interim perspective on the agency, because it's a good question. And as Matt said, and as Rob has said, the agency reduction is a significant part of the difficult decisions, grip and control work we're doing. We'll be concentrating on that shortly. For Aintree, as Matt said, it's ED, escalation and quick care, although we've just gone through some equipment into vacancies and quick care, and still we're beginning to see that come down, right? So it gives some assurance on that. There's also a pocket in the theatres But that was deliberate because we were previously relying on insourcing. So we moved from insourcing to agencies. That's cheaper, but we're moving now through a recruitment process to try and wean ourselves down on that game. And we're tracking that weekly in our actual recovery plan to make sure we've just made discounted thesis too. So it's currently watched, as Matt said, at both sides.
We're using some great tools here to work at our safety staffing levels. I just wondered, I'm sorry if I've missed it in the report, is what benchmarking work do we do in terms of other similar organisations and the staffing ratios that we're using?
So apart from areas like critical care, we've moved away from staffing ratios. They were brought in probably about 10 years ago, were only used for a short period of time. The emphasis on the tools is around acuity of those patients. And so, for instance, we are doing we're part of a national collaborative looking at those patients that require additional care, enhanced therapeutic observations of care, one-to-ones or specials, as we would previously call them, around how we utilise that additional workforce and then what we do with them and how we measure against other organisations. So we're doing that on particular pockets, but yeah, we have moved away from ratios.
Okay.
It brings us out in hives.
Thank you. Any other points? Received the report. Yeah, Kinton, thank you.
Thank you.
Welcome, David. Right, 10-point plan to improve residents' doctors' working life.
Yeah. So board members remember that in November I brought the first version on this, the first submissions, and this was just a way to update because we were required to submit to NHS England after 12 weeks the progress we had made on the 10-point plan. And actually, I've got the scores on the doors, so I thought that would be interesting.
Like scores.
Yeah. So in the baseline admission, the baseline Liverpool women's, so the percentages they're worked out through some algorithm. So in the baseline submissions, Liverpool women's baseline submission was 79%, Liverpool Heart Chest was 69%, Lufts was 58%. And then at 12 weeks, the submissions were Liverpool Women's Hospital had improved to 84%. That's 8 points movement. Liverpool Heart and Chest improved from 69% to 77%. That's 8 points movement. And Luft had improved from 58% to 80% share. That is 22 points movement. And so I hope you'll agree that's moved in the right direction. What I've put in the paper is a little bit about how we've done that. So the 10 points are listed. We've appointed resident doctor leads for each of the sites. So we've got the embedded ambassadors. Of course, we've got 3 chief registrars, so we've got good capacity in that regard. And I've given you the names of the colleagues at the other sites, all of whom are chairing resident doctor committees. So acting as the conduit between the trusts and resident doctors. We've also got an SAS doctor advocate in Anu Shroptree, who I met with this morning and has agreed to be the group for SAS doctors. So I'm very pleased about that. Some of what this is about is getting the basic administrative functions right. And I point out that in terms of rostering systems, we've still got some IT challenges in that department to work on, but that's an opportunity for us, the whole group. So that's being looked at the moment. We kind of need to remember that we're talking about groups of doctors who are moving through the system. They're moving at least every 6 months, sometimes more frequently than that. And therefore, there are some real, I think, honestly, logistical challenges in terms of keeping on top. But we've seen real commitment from our medical staffing teams to respond and address things. So I think we've seen material improvements. Heather and I talk about that, in particular the LNCs, for example, about how that's going. We get feedback through the hospital medical boards. So this isn't the end of the matter, Chair. We will keep going, but I would like the board to know the improvements.
Very significant improvements in all the organisations. The 22-point improvement is very good for in future for drafting of reports and reporting progress on things. 22 points is now the to
It's hilarious, please. Welcome, Jim. So, the points, questions, concerns? Thank you very much. The Guardian of Safe Working Q2, Jim, please, still with you.
Thanks. Yeah, there's a kind of link here, isn't there? Because we have guardians of safe working. These are doctors who are employed by the trusts to make sure that the 2016 contractual regs for resident doctors are observed. And essentially, we have a system, don't we, for resident doctors who feel either that they are under unreasonable pressure on their shifts or they are being asked to stay later to do more than is expected, as they have the ability to exception. That's what this is about. So I've had a look at the reports from all three trusts. I point out in the paper that these two quarters 2 and 3, there were 3 sets of industrial action, so that's 15 days of industrial action, so not insignificant in terms of, we've touched on that already. I've drawn out something which we perhaps touched on already a little bit, which there's been a different challenge, particularly in quarter 3, around some changes to the extra contractual rate card for resident doctors, which is something that we were trying to do across the whole of the ICB, and we were working within and with the ICB on that piece. And that's something that I put on the risk register because it created some new tensions in terms of filling shifts. And actually, we've discussed that in separate meetings this week, but I think we were right on the risk register and we've responded to that risk. So there's something in the paper about the reality of filling rotas, because 20% at least of our resident doctors now don't work. They're rotating at least 6 monthly. It's very difficult to predict where those gaps are going to appear. So it seems pretty inevitable that unless if you will, over-recruit to establishment in terms of clinical fellows and so forth, we're always going to have some gaps that we need to fill. The trick is to try and get as close as possible, I think, to that. I think there's a lot more attention going on to the demand capacity kind of balance as we work. Something I think is important to note, though, is when you look at the exception reporting across Aintree and the Royal, there is clearly more exception reporting on this side than at the Royal. And in previous times when I've reported this, I thought this was due to an imbalance of foundation track doctors, so the most junior doctors. But I genuinely believe we put that right there, worked on that. So if that reporting is still taking place, my hypothesis is that there are some pressures in the middle grade resident doctors. So who is supporting the most junior doctors? So I think that needs to be the next focus for us on the 2 big hospital sites, is have we got the middle grade doctors right? And we've got the Guardians working on that now, so I'll bring that, we'll make sure that information comes back. Down the line, possibly imminently, as early as February the 4th, there are some slightly tighter regs due to come in place around exception reporting. And the reason that's been delayed, because I've talked about that before, is to do with a software upgrade, which is a national issue. So we're still expecting to do that on the 4th of February, but it might not happen because the software still hasn't been upgraded nationally. Nevertheless, it's really just, it fits a bit with the 10-point plan. It's about having the tight systems to make sure that we report better.
Thank you, Jim. And in your paper, a good clinical leadership structure now around this across all of the sites. Because at one time going back, that was a challenge.
I think so. I think it's clear you've got to have people on site. They've got to be visible, they've got to be accessible, and we've got that built in.
Thank you. Next question, Tom, please.
Thank you, Jim. We heard yesterday that the issues around medical registrar covering the Royal. Yeah, one medical registrar instead of 2, or at times no medical registrar at all. Did that come to life through this process, or was it reported through this process?
Yes, the answer to that is yes. I think it does, particularly in Q3. That's we can very easily get our heads around that, can't we? There should be 2, and we've got 1. The system therefore is under a lot of pressure. That's bound to be stressing people out. I think there's something slightly harder, more subtle to pick out, for example, in just the way the rotas are constructed. And I think that's more marked on this side than it is of the rule. But the answer to your question is yes.
Okay, let's receive the report. Thank you. That brings us to the end of our agenda business. Mike, it's about the audit report.
Yes, Chair.
Okay, no, so Mike reminded me what it was, but I'll go back to you.
Yes, thank you. The apologies, and it took me a while to get the audit papers up and admin control. I didn't put it on my notes. So we have 4 reports that gave us substantial assurance, risk management controls, general ledger, accounts payable, and accounts receivable. And there was a 5th report that we've commissioned on a payroll review, and it covered encouragingly both Luft and Liverpool Women's Hospital, looking at how whole-time equivalents are derived from payments going through the payroll. And because it was not a full audit report, an assurance level wasn't allocated to it, wasn't required.
Yeah, thank you.
We've had it at my fingertips. Sorry, Chair.
No, that's fine. That's all clear. So that brings us to the end of the agenda business. Time. James, you've been observing us for a while. You won't have been able to identify through your screen view some of the body language, the eyebrow, the moments at which eyebrows were raised or eyes were rolled. But so it's harder when you're remote. But is anything you'd like to say before I close the meeting?
No, I did get some of it, but no, mainly down the side of the table. No, I'm happy to share with that. I think the key discussions obviously are coming up in the private session around the financial planning, because that's the area where we've got the biggest challenge. So yeah, very, very happy with what I've seen. Thank you.
Thank you. Daniel, unless I've missed anything, is anything new for the risk register that we haven't already got embedded? We've not received any advanced questions. People have read the papers in advance of the meeting this time.
Just the only question was the one I referenced earlier about enforcement undertaking that came.
Yeah. Okay, thank you. So we come to the end of this meeting. Thank you all very much for your contributions, for your preparation, contributions in the meeting. Covered a lot of ground. The date of next meeting is?
Yes.
So we come together in assurance and risk next month. Thank you all very much indeed. We resume in private session scheduled for 3 o'clock start. Colleagues content if we start at 5 to 3? That give everybody time to do the necessary. Thank you very much indeed. Meeting closed.
Thank you.
Okay.